Welcome everyone for the second day. We had a lot of administrative issues yesterday, which may be a bit dry, so we'll hope to be a bit more applied today. And this is what Sonia told you on the therapeutic side of vestibular disorders. So last training school, we tried to show you how we diagnose patients, how the pathophysiology of disorders is like, and now we are moving on to current treatments. And just to show you a bit, we have these very diverse causes of peripheral and central vestibular disorders running from the semicircular canals to nerves to central systems. And of course, there is not the one treatment for all of these diverse disorders, but the key to a good treatment actually is to understand its pathophysiology, its etiology, and then try to base the treatment on this pathophysiology and gain as much evidence as you can have. Good morning. So that is when issues start already, because in our field there is not a long tradition of high quality randomized controlled trials. So there is a evidence lack and a evidence gap for most of the treatments we do. And this is what I just closely wanted to introduce, where maybe the challenges are and where we stand, and this should be the basement for the further talks you will hear. So actually, we always say we treat patients, it's a multimodal treatment, and multimodal means you have physical elements, that is the traditional vestibular rehabilitation, you have pharmacology, you may have new devices and neuromodulatory approaches, and of course you may always consider that our patients also have a high burden of secondary psychiatric, psychological problems. So that needs always to be considered, that psychological and cognitive therapies, at least for chronic patients, is really important in our treatment strategies. So of course vestibular rehabilitation is very well known for a long time, and the principles are clear, and of course the evidence for its action is quite high. And just one example is that if you treat a BPPV, it's quite clear that is a biomechanical inner ear disorder. You have to do a certain exercising, and then you're likely to cure the patients quite well. And of course that is one example of how you could base your treatments of understanding of pathophysiology and then do guided therapies. Of course, we also have evidence for the action of vestibular rehabilitation, and Klaus will talk about that. It is moderate to strong, so we can say it works, but what we can't say is how it works. And that is the other question, that at times we use a lot of kind of treatments which, es funktioniert. Alles gut, ja. Okay. We have a set of treatments which we use, and they function in everyday's life, but we don't know explicitly on how they act. And this is at times when you also start doing back translations, for example, to animal models, and that has been done also by some groups, also by Christian Rabert's group. They started to understand what kind of neurobiology lies behind the effectiveness of vestibular rehabilitation. And of course, that may also feed back to more appropriate protocols which we use in clinics. So as a pharmacology, of course, I think we have those two big groups of medications. The one, again, is used for decades and nobody knows how it works, and it lacks a lot of evidence if it works against placebo. And the other is new principles which are somewhat repurposed from other disorders to the vestibular field in order to tackle certain subgroups of disorders. And the traditional way of thinking is, if you use a medication, you don't know how it works, you get back to the lab, this is back translation, or you have evidence from the lab, for example, what Christian and Brahim showed, like for thyroxine in animal models, you can also translate it back to patients. And I think this bidirectional translation is key to use of pharmacology on purpose. And just one example on a disorder which is quite frequent, at least in chronic patients, that is so-called downbeating nystagmus. It's a most common form of a central fixation nystagmus. And this is an example where really that whole translational chain was followed. So first was to understand where is the problem. So that's what we know now. It's a problem in the vestibular cerebellum and the flocculus. So the cells are functioning less, and that can also be shown in animal models. There is animal models also like the tottering mouse or other mutations which can be used as a animal model, and then you can start doing preclinical experimentation, for example, with the aminopyridine group. It worked, it translated to early clinical trials, it was kind of confirmed, and then it was repurposed for different other cerebellar disorders. And at the end of the line, now we know that the etiology of most of these cases is genetic. We can also do a personalized counseling of who will likely respond to aminopyridines or not, which is depending on the specific etiology of damage. So that would be a success story of where, you know, that whole chain has been followed, but it took 25 years. So other things are less clear. For example, the kind of famous story of beta-histine, which always leads to a lot of debate in clinical meetings, if it's useful, if it isn't. And just to show you shortly what maybe the problem is, that we know from animal models it is effective. It has been shown many times, but then clinical trials using it failed to show an effect against placebo. And then people said, okay, likely that is not effective in humans. And then if you have this kind of failure of translation, you always have to think, why is it? Why is the effect in rats perfect and in humans so bad? And then you have to think about simple things, and this is just of application. So in rats, it has often been applied parenterally, like IP or SC. In humans, it's given as a tablet, it's oral. And then you talk to your pharmacologist who says it's quite clear that the beta-histine gets metabolized via MAO-B enzymes in the gut and liver, and you lose 99% of its effect if you take it on an oral route. So that is maybe part of the explanation for this failure of translation. And then you have to rethink and say, okay, maybe we combine it with another medication, which is a MAO-B inhibitor, and then we may overcome these translational issues. And this is where we are in the moment, and studies are being planned to see if that is really true. But just to show you, there's a lot of potential options for failure of translation if you don't consider species-specific and also pharmacokinetic aspects. So that's just for short notice. I think Klaus will give more on this pharmacology in his talk. Then we lately had, of course, this fascinating developments of new tools and neuromodulatory aspects. Of course, the vestibular cochlear implant, as you know, the analog of the cochlear implant for hearing loss. We have the balance belt for proprioceptive biofeedback. We have stochastic resonance with noisy galvanic vestibular stimulation. And I think we have two wonderful talks who will cover this field. And just to end up again, psychological cognitive therapies are most important also in counseling of patients, because it's always this triple of, you have structural disorders, you have then a potentially psychiatric response to it, and that may feed back to bodily symptoms. So just kind of this continuum of origin from, structural vestibular damage, but also response of patients. And that's why also our function tests always translate one-to-one to the feeling of patients. So it may be you have a severely impaired vestibular patient, but he feels quite good, or it is mildly affected, but they feel quite bad. So, and the kind of explanation for this heterogeneity is also on the cognitive and behavioral strategies of patients to cope these problems. But, we don't have any good evidence of the appropriate treatment strategies for these patients. Is it in triple PD, or is it for, secondary functional dizziness to organic disorders? There's not much evidence for that. And I think we need to have good and well-designed trials in the future. So This is just a short introduction of what you may expect for this morning. So we'll have more dedicated talks on vestibular rehabilitation and medication by Klaus Jahn, and then Hermann Kingma and Max Wühr on the neuromodulatory approaches, and end up then with the vestibular cochlear implant in the end. And hope that this also prompts a lot of discussions, because one of the major aspects of this network is that you have all these people in one room, which is quite unconventional, and that will also lead hopefully to more in-depth discussions. So thank you very much.